Okay, let's dive right into this explainer. Today, we're tackling a really fascinating friction point in modern medicine. You know, what actually happens when standard, rigid clinical rules collide with a complex, real world human being? We're breaking down Lesson 12 of Dr. Avinash Kumar Gupta's Clinical Cognition from First Principles course on Vibrowns. Specifically, we're zooming in on precision medicine and personalized care.
Imagine for a second that you are the clinician. You're sitting in an exam room and you have a 75-year-old patient sitting right across from you. Now, technically, according to literally every single guideline you've ever memorized, this patient needs a standard aggressive treatment. But they're extremely frail, and their specific unique combination of health issues means that the textbook answer, while totally correct for the general population, is actually potentially dangerous for this specific person. So how do you bear the cognitive load of veering off that established path? Well, that is exactly what we are going to untangle today using a structured Socratic approach.
But before we can personalize care, we really need to define our terms here. Clinical cognition is basically the art of making the invisible reasoning behind a diagnosis, well, visible. It's that structured journey from raw findings to a final judgment. Now contrast that with its sibling course, evidence-based medicine, which asks, can we trust this evidence? Clinical cognition asks a much more functional question. How do we actually process that evidence to get from these symptoms to a safe decision? It's not just about the final conclusion. It is all about how the reasoning actively moves. To understand how this reasoning adapts, we're going to walk through a clear mental map of 4 specific cognitive personalization layers today. 1. Checking applicability. 2. Resolving conflicting evidence. 3. Weighing patient preference. And 4. Documenting deviation. So let's jump straight into Section 1, checking applicability. This sets the stage for what happens when standard medical evidence meets a unique individual. Right, so before a clinician can even begin to check if evidence applies to a specific patient, they absolutely must establish what Dr. Gupta calls the core loop. We covered this in the first 9 lessons. Think of it like checking the foundation of a house before you try to build the upper floors, right? You just can't personalize care if you haven't first laid down a rock-solid base of observation, built a probability-weighted differential, and honestly audited yourself for biases. Once that rigorous foundation is poured, only then can you stack these personalization layers on top. You really have to know the standard rule perfectly before you can even start to figure out if it actually applies. Moving on to Section 2, resolving conflicting evidence. Now, what's really interesting about this slide is how it shows the way doctors handle competing data. So population data tells us what works for most people most of the time. Like, say, a statin dramatically reducing heart attacks across a registry of 10,000 people. But what happens when the one individual sitting right in front of you has comorbidities that were explicitly excluded from those exact same clinical trials? These two domains genuinely, and sometimes dramatically, diverge. Resolving this conflict isn't just guesswork. It requires a highly structured cognitive process to safely weigh whether that population math can actually stretch to fit the human reality in the exam room. Which brings us to Section 3, weighing patient preference. This is the crucial human element that absolutely has to be integrated into all this clinical data. As you'll see here, a clinician doesn't just dictate care based solely on clinical evidence. No. They have to juggle that evidence against patient values and risk tolerance in this incredible multivariable equation. Let's go back to our 75-year-old patient for a second. If the clinical evidence suggests, an aggressive surgery, but the patient values just playing with their grandkids over extending their life by a few statistically possible months, and maybe they have a very low risk tolerance for surgical complications, well then that correct textbook answer is fundamentally wrong for them. True precision medicine is a real game changer because it perfectly merges the subjective, lived experience of the patient with the objective science of the doctor. And finally, Section 4, documenting the deviation. When a clinician decides to step off that standard path, they must leave a clear reasoning trace. Documenting the deviation. Now, you might be tempted to think of documentation as just some tedious administrative chore. I get it. But within this framework, it is the exact opposite. Documenting exactly why you deviated from the standard protocol is the final, absolutely crucial step in the clinical reasoning loop. It's all about systems thinking, and ultimately, it's about safety. Because if you don't document that specific probability-weighted Socratic reasoning that led you to personalize a treatment, the next doctor who sees that patient won't understand your mental trace at all. They're just going to see a medical error. Documenting the deviation guarantees cognitive transparency across the entire healthcare system. So what does this all mean? The absolute main takeaway here is making the invisible reasoning process visible. When we hear the phrase precision medicine, we usually imagine like sci-fi genetic sequencing or some futuristic tech. But what this curriculum shows us is that true personalized care is actually a highly disciplined operating system for the mind. It is the rigorous, step-by-step application of auditing biases, checking applicability, resolving evidence conflicts, and deeply weighing human values. And this matters immensely, because whether you're the clinician or the patient, this structured cognition is quite literally the only way to safely adapt rigid science to a complex, fragile human being.
Which leaves us with this final drop the mic kind of question. You've just seen the rigorous, highly visible steps required to safely deviate from the norm. But experienced clinicians often seem to make these incredibly complex, personalized decisions in the blink of an eye. So how does this deliberate, structured deviation eventually compress into a clinician's rapid, intuitive mastery? I mean, what is the actual difference between real expertise and a dangerous shortcut? Well, that exact transition is the focus of Lesson 13 on clinical wisdom, and I highly recommend you keep exploring to find out. Thank you so much for joining me for this explainer, and as always, keep questioning the process.